almost like very soon thereafter without dragging it all sorts of places. So that was a handy feature.
Yeah, thanks for that. Doesn't seem to work.
All right. All right. Look, I think we're going to start. So welcome everybody again to another of our Sydney Neonatal Lecture webinars. And it's a pleasure to introduce Sheryle Rogerson. She is a neonatologist at the Royal Women's Hospital in Melbourne and one of the founding members of the ASIM neonatal ultrasound, and a deep passion into ultrasound. Whether this is cardiac or otherwise, brain, lungs, any bits and pieces. But I know Sheryle for a long time. She runs a workshop or a sort of a meeting on a Monday night where particularly hemodynamic interested can join to just discuss cases and have a more of an informal, formal talk about mostly neonatal hemodynamics, but generally what has to do with ultrasound. And I asked her today, and she said, "Oh, you want to talk for us?" And she said, "I got something which I presented, and it is, of course, the cardiac adaptation in twin-to-twin transfusion syndrome. This is a remarkable condition, and I'll leave it to Sheryle to explain to us what we as neonatologists can encounter when we have to take care of these babies, especially when they're born preterm." All right, Sheryle, over to you.
Hi. Welcome everyone. So thank you, Kurt. So, okay, so twin-to-twin is not a very common problem. So from the 2022 data, as 3% of all births in Australia are twins. In New Zealand, that's about 2%. I refer to New Zealand because I thought there might be some people from New Zealand on the group as well. There's 4,300 births were registered as twins. In New Zealand, there was a lot lower number, 1,100. 33% of twins are monochorionic, and 20% of twins that are monochorionic will get twin-to-twin transfusion syndrome. So really, during our neonatal exposure as neonatal consultants, we're not actually going to see this condition very much. But when we do see it, we really need to know how to manage it. And a lot of the articles are really about sort of pre-management. And now that we've got fetal laser, ligation of the anastomoses, we're seeing less. This is going to become a rare condition and very difficult to do research on, very difficult to do any sort of randomized trials. So 70% of identical twins are monochorionic. So you can actually get twin-to-twin not all identical twins are monochorionic. And so therefore, really, we just need about 283 pregnancies in Australia. Okay, so twin-to-twin complications that you can get you can get the twin-to-twin transfusion syndrome, which is what we're talking about today. You can get sort of like anemia, polycythemia sequence, which the infants are, one's anemic, one's polycythemic, but they don't get the full twin-to-twin syndrome that we're talking about today. You can get selective fetal growth restriction, and that's generally related to insertion of the placenta and the insertion of the umbilical cord. And obviously, with all of these twin pregnancies, you've got a higher rate of prematurity and all the related complications of prematurity. You do have premature rupture of membranes, especially of one twin versus the other. And there's an increased incidence of cerebral hemorrhage and or ischemia in twin pregnancies, monochorionic twin pregnancies. So I thought, as this is a little bit about like my area of interest, which is ultrasound and ultrasound use, I would actually just present a case. So this is donor twin. This is the donor twin who happen to be twin 2. So these infants generally present with oligohydramnios, oliguria, and fetal growth restriction. They were delivered by emergency cesarean section for Doppler reversal in the ductus venosus and the ductus arteriosus, and that is generally what occurs in the donor twin. The 20-week scan was normal, and by the time they diagnosed twin to twin, the mother was not suitable for fetal laser therapy. And so this infant was born very low birth weight, 518 grams, at 28 weeks, had extensive resuscitation, did actually have delayed cord clamping at birth because it was twin 2, was intubated for, with CPR, heart rate was less than 60, and was given packed red blood cells, but was persistently hypotensive with a mean blood pressure of 26 and falling. Okay, so, this is the sort of echo that these twins are going to present with. So you've got very poor contractility, you have a dilated left ventricle, and relatively poor function. And then as we go on to the next slide, you can see continue, you've got a dilated right ventricle, a generally dilated heart, and relatively poor function, virtually no longitudinal function, and very poor circumferential function as well. So this is a heart that is failing. And the ejection fraction at its worst was recorded as 8%. So for the donor, they had dilated right ventricle, poor contractility, had a very low left ventricular output velocity of 37 meters per second, had a reasonable left ventricular output, and had a very low TAPSE. So we've got right ventricular and left ventricular dysfunction in this infant. And there was left ventricular output was 133 mils. And so dobutamine and noradrenaline was suggested to try and improve the contractility of this for this infant and offload the right ventricle. So the recipient, as you all know, is generally got polyhydramnios, polyuria, and may or may not have fetal hydrops. So this infant was obviously born at 28 plus 5, was 1.1 kilos, twice the size of the other twin. Same history, not suitable for laser therapy. But this infant was extremely well at delivery, was given CPAP of 7, required oxygen of about 30%. But then at 10 hours of age was noted to have progressively worsening perfusion, had a capillary refill time of 4, was suddenly requiring 100% oxygen, was intubated, didn't have a very high lactate, and had a reasonably normal hemoglobin of 132. So this is the echo of your recipient. He had a tricuspid regurgitant jet, which is 2.8 meters per second. But what you can see here, instead of a dilated heart, it's just got gross hypertrophy. This is all muscle. You can hardly see a right ventricle output. You can hardly see a left ventricle cavity. So this is what this infant is dealing with, sort of a very hypertrophied, abnormal heart. So just seeing it in the apical view, this is your left ventricle here, and all of this is muscular hypertrophy of the free wall. You've got interventricular septum is hypertrophied. You've got hypertrophy of your right ventricle. This is the tiny right ventricle cavity just here, and this is your left ventricle cavity, and this is your left ventricular outflow tract. And then as we go down to the next slide, you can see that for this particular infant, we were looking to see, is there any mitral regurgitation, suggestive that there was left ventricular outflow tract obstruction, because this muscle becomes so hypertrophied, it causes right ventricular outflow tract obstruction and left ventricular outflow tract obstruction. This infant also had pulmonary stenosis with a TR gradient of 2.8 meters per second, but you need to be very careful because in the recipient twin, there is an increased incidence of pulmonary stenosis. And once you've got pulmonary stenosis, you can't really confirm what your pulmonary pressures are just from the tricuspid regurgitant jet. Okay. All right, So in for twin 2, twin 1, who was the recipient, was currently on nitric oxide and noradrenaline, dobutamine, and eventually things improved. The left ventricular output improved to 145 mils. It was previously 50. The right ventricular output really was unchanged. There continued to be quite significant right ventricular dysfunction, and there was also pulmonary stenosis diagnosed. The left ventricle gradually appeared to be slightly larger, and the right ventricle was also just a little bit larger to the eye. So these twins had a very severe cardiomyopathy. One's got a dilated cardiomyopathy, one's got a hypertrophic cardiomyopathy, and they need to be managed quite separately, but they both showed the typical trajectory of the anemic twin being more unwell immediately, but then the hypertrophic twin getting into more trouble at 10 to 24 hours of life as they become increasingly volume deplete. So the placenta is a really complex organ. And Placentology, which comes out each month, is a very, very thick journal when it used to be printed. But so twin-to-twin pregnancies that are affected are more likely to have a velamentous insertion. So that means an insertion that's off to the center into the placenta. You've got a higher proportion with a magistral pattern to the vessels. So that means that instead of the vessel diameter getting smaller and smaller as it goes away from the cord insertion, the actual placental vessels do not change diameter. And so therefore you get increased flow from one twin to the other twin. And the placenta itself actually has apoptosis, and you get reduction of your bidirectional AVAs and VAAs, but there's progressive asymmetric reduction of these arteriovenous anastomoses, and which occurs between the donor and the recipient. It's not all just due to volume. The initial sort of volume overload can then cause these other hormonal adaptations, which then really complicate the management of these twins once they're delivered. So to start with, you have atrial dilation in the recipient, which leads to increased atrionatriuretic peptide, which leads to increased glomerular filtration and decreased tubular reabsorption. You have increased brain natriuretic peptide related to your atrial dilation and endothelium. And this actually is related to structural cardiac damage and the remodeling that is going on with this hypertrophic cardiomyopathy of the recipient. The BNP level is correlated to the recipient's cardiac dysfunction and the severity of the twin-to-twin transfusion syndrome. But once they've had fetal laser therapy, it's not as reliable. The infant also is hypovolemic, and so therefore has suppression of its angiotensin, renin-angiotensin system. But in actual fact, the levels are increased from the donor who's actually providing a large amount of angiotensin to this infant. And the infant then becomes relatively immune to angiotensin because the polycythemic infant is still actually polyuric, despite having very high levels of angiotensin from the renin-angiotensin system. So the BNP is worthwhile knowing antenatally. The higher the level, the worse the cardiac hypertrophy. And these increased levels of vasoactive substances, you've got hypervolemia, you get cardiac function, cardiac failure, and you get cardiac hypertrophy. For the donor, they have a relative hypoperfusion, they have renal hypoperfusion, they have oliguria and oligohydramnios. They actually get renal kidney remodeling, and they get renal tubular dysplasia and atrophy, which their kidneys actually never fully recover from. The renin-angiotensin system is significantly increased, and this increases the arterial resistance in the donor's placenta. So therefore, that has upstream effects to your ductus venosus, ductus arteriosus, osseous flow. And you have decreased umbilical arterial flow, you have IUGR, and you actually have long-term arterial remodeling and stiffness. And these infants get hypertension later on in life. You have other hormonal effects which are not fully well understood as to how they affect you in the post-neonatal period, but you do get increased nitric oxide synthetase in the donor and the recipient. And in the recipient, you get increased VEGF, your vascular endothelial growth factor. This is obviously sometimes used for prevention of neonatal lung injury. And it's also anti-VEGF is used for ROP prevention. So these infants have a very high level once they're born. So infants who have had twin-to-twin transfusion syndrome, they have a 12 times more increased incidence of congenital heart disease than the general population. So it's really important that both children get an echo at some stage. They have disturbance of laterality and phenotype, leads to discordant cardiovascular disease, which you're all well aware of, identical twins where one's got a significant cardiac lesion and the other one has no lesion. Pulmonary valvular disease is the most common cardiac abnormality, and pulmonary valvular stenosis is the most common abnormality in the recipient, and that occurs about 3% of all recipients. We'll go on to why a bit later. So the recipient generally has hypertension, biventricular hypertrophy, plus or minus left ventricular outflow tract obstruction, tricuspid regurgitation in association with pulmonary hypertension. They have ventricular hypokinesia, so they have a very, even though the muscle, there's a large amount of muscle, they have very poor contractility. They often have right ventricular outflow tract obstruction from the hypertrophy of the muscle, but also in association with the pulmonary stenosis. They have low right ventricular outflow because they've got TR as well as potential hypertrophy. They have an increased systemic vascular resistance as measured by mean arterial pressure minus your right arterial pressure divided by your left ventricular outflow, but that needs to be done in liters per kilogram per minute, and that will give you a dyne of your systemic vascular resistance. They have diastolic dysfunction, they have a restrictive cardiomyopathy, they may have a dilated LA, and that may cause then pulmonary venous congestion, so therefore they have a postcapillary, may have a postcapillary pulmonary hypertensive pattern. But in the long term, they have hypertrophied myocardial cells, and even when the hypertrophy resolves, these infants are left with scarring, permanent scarring of their heart. The recipient often also has a little bit of right ventricular failure with a very low TAPSE. They have increased myocardial performance index, and they'll have increased calcification of the aorta and the pulmonary artery, and this can have effects on their long-term vascular desensibility. The donor who's hypovolemic will often have poor left ventricular output, leads to a relatively smaller left ventricle, and it has been shown that there's a slight increase in aortic coarctation for the donor and potentially aortic stenosis, but not as much as pulmonary stenosis for the recipient. They are exposed to early onset adult hypertension and ischemic heart disease in survivors. And they should have long-term surveillance for their blood pressure, especially in the teenage years. So after fetal laser therapy, it's really important to know how quickly it improves. So a lot of these infants will improve, and some of the things that we've seen before fetal laser therapy aren't as prominent, but certainly the congenital heart disease with the pulmonary stenosis is still quite common. So survival is good. You have at least an 80% chance of survival of one twin. And so in the recipient, the tricuspid regurgitation disappears within 48 hours. And also within 48 hours, the cardiac size has started to decrease. So the cardiomyocytes recover really quickly in utero, and they stop being so hypertrophied. They have an improvement in their myocardial performance index. And the survival of the recipient is significantly reduced if you don't see these improvements quickly after the fetal laser therapy. If this infant delivers sort of within that 48-hour window, you will see improved function, but the hypertrophy lasts for longer and the function takes a lot longer to improve than would happen if the infant was in utero. So the infant has an altered response to their renin-angiotensin system as they're a volume-loaded fetus. They've been exposed to high levels of angiotensin, but they're still actually pouring out a lot of urine despite these high levels of angiotensin. For the donor, it's not as good a story, actually. They have a worse cardiac function after their fetal laser therapy. These infants are volume loaded, and the left ventricle doesn't tolerate the increased volume and pressure load after the fetal laser therapy that occurs. The left ventricle does not cope well with this acute pressure load that they get after the fetal laser therapy. They actually get an increase in their cardiac size, which would be good, except that it's now dilated and not contracting as well as it was before. Their TR can be worse, and in actual fact, they can develop some subcutaneous edema after their fetal laser therapy. And this recovers very slowly. So the impact of the sudden increase in volume takes quite a while for the infant to recover from. Their renin-angiotensin system is still pumping out angiotensin. So now they are no longer donating to the recipient, but they're also still retaining fluid, and their renal failure persists for 1 to 2 weeks after their therapy. So these infants are at risk of volume loading and poor left ventricular function after birth if they are delivered very early after the fetal laser therapy, because they haven't had time to adjust and get rid of the increased renin-angiotensin system. So fluid boluses are definitely not recommended in the donor, and if the donor is still anemic, even after the fetal laser therapy, it should be given very carefully. So when you're assessing for your hypertrophies, you really need to sort of look at your infants. You really want to be focused on the cardiac structure, specifically looking for pulmonary stenosis and coarctation. You really want to be focused on your left ventricular systolic and your diastolic function, because these are the areas where these infants have very poor systolic and diastolic function of both the right and the left ventricle. And these are the parameters that we use in echocardiology to assess the diastolic function of the left ventricle. And with this information, then we can helpfully and hopefully provide the best inotrope for these hypertrophies. Albeit some people would say you should try not to give any inotropes for these infants. And obviously, for those of you who do echoes, you can see you've got a very thick myocardium here. So the interventricular septum should be about 3 plus the weight. And if it's greater than that, you should really need to consider hypertrophy. And there's some really good values out there for the preterm infant, which shows what the 3rd to the 97th centile for your interventricular septum is. And then often people talk about systolic anterior movement of your mitral valve. And this is related to the very small cavity. And when the left ventricle contracts, what you actually see is the in systole, the anterior leaflet of the mitral valve moves forward and obstructs the left ventricular outflow tract. So you need to be really careful with these infants, and that's why it's really important to do an echo early before these infants get into trouble. So with hypertrophic cardiomyopathy in the recipient twin, we should be trying to avoid tachycardia. We absolutely need to avoid diuretics and dehydration. If they are born preterm and they have severe lung disease, these infants would be the ones that you would definitely try and avoid any postnatal steroids to avoid worsening their hypertrophy. And their hypertrophy will generally improve over the next 2 to 4 weeks, but it's not as quickly as if they'd stayed in utero. And I think the most important thing for managing these babies is to reassess what their cardiac function is doing after any treatment, because if you make them too tachycardic, you may actually make their left ventricular output worse. And most of our inotropes will actually make the infant slightly more tachycardic. We've sort of talked about what happens for the neonate. They're higher increased incidence of pulmonary stenosis. They have a higher incidence of pulmonary hypertension because of all of the vascular components that are going on, the vascular hormones. They're difficult to assess if they have pulmonary stenosis. It's difficult to assess their pulmonary hypertension. And the recipient will often have interventricular hemorrhage. And then, so in the Senate study, they also had a 21% incidence of cystic PVL, which obviously you would see around the 6-week mark. There are some reports of limb ischemia, and it's a bit unclear what that's due to, either to the polycythemia or the hyperviscosity. And obviously, you would need to manage that if you thought that that was a significant problem, polycythemia and hyperviscosity in your infant. For the donor has a difficult neonatal period. They often have renal failure, but generally 34% generally in this, it's very short term. And also if they've had fetal laser therapy, they will have resolved most of their renal failure by the time they're born, but they will have ongoing scarring of their kidneys and relative renal hypoplasia. They're obviously anemic, but as we mentioned before, you want to be careful about just giving them fluid bolus or just giving them blood, because volume overload needs to be avoided because they have relative renal failure in association with their cardiac failure and their low protein and albumin. And obviously, I'm really talking about the infant that's been born before they've been fully adapted after their fetal laser therapy, or for the infant that didn't ever get fetal laser therapy. Okay, so they actually have problems with their long-term cardiac function. So these people looked at their long-term cardiac function. So it was a prospective follow-up of fetuses with severe TTS treated by laser coagulation, and then fetal echocardiography and Doppler studies. So they did them in the fetus, and then they did them at approximately 2 years of age. So the echocardiography was normal in 87% of survivors. There was congenital heart disease in 11% of the survivors. Pulmonary stenosis was only recorded in the recipients. And there was an increase in atrial septal defects in the donor. So these are just like 2-year outcomes. But generally their long-term cardiac function is okay, except for then if they go on to develop hypertension in the donor twin. So twins with no twin-to-twin transfusion, those twins who are born at less than 32 weeks with no twin-to-twin, they do as well as singleton pregnancies. So really twin-to-twin really alters their long-term outcome, alters their long-term neurological development, and certainly alters their early progress through the neonatal unit. So the take-home points for this very short lecture is twin-to-twins, both infants need an early echo to assess right ventricular function, left ventricular output, and contractility. After fetal laser therapy, recipients improves more quickly than the donor, and the donor is at more significant risk of acute demise. If they deliver 1 to 2 days after your fetal laser therapy, you need to consider their hormonal effects, and the cardiac improvements will be slower than what they see in utero. There's associated and discordant congenital heart disease, which is mainly pulmonary stenosis. The donor is more likely to have an atrial septal defect with arterial stiffness and adult hypertension. And so we should keep the recipient volume loaded, be very careful with starting inotropes in the recipient, and we should keep the donor sort of isovolemic. We shouldn't let the donor get too volume loaded because their heart is not going to be able to cope with it as well. And I think the other key thing is to reassess after starting with any inotrope, especially the recipient. And I think that's all I have to say, really. It's a pretty short talk, but I thought that there might be quite a few questions.
Thanks, Cheryl. That was a very comprehensive overview on, indeed, like you say, cases which are not that common anymore. So the descriptors come from case reports, some small case series, and people who gave this some thought by actually doing measurements at the bedside serially, particularly in these babies. We'll wait till some chat box come in, some questions. Please put them into your chat box or unmute yourself. Maybe I'll start off. Cheryl, these recipients with their hypertrophy and their inappropriate RAS activation, is there a room for question number 1, ACE inhibitors, and question number 2, vasopressin?
So I don't think I really know the full answer to that. I didn't see any studies I didn't find any studies quickly available that had talked about the use of vasopressin or ACE inhibitors. So when we would so for the hypertrophic infants, they will get better generally on their own, and when we were discussing this particular infant, they really didn't feel that beta blockers would be of any use, which is what you sometimes use in the hypertrophied infant. And they felt that if there was really significant left ventricular or poor left ventricular output, that possibly we would consider ACE inhibitors. But I don't know that there's been a lot of work in it that I know about, but that may be just that I haven't been reading up on it. And I wouldn't have thought that vasopressor and really constricting these vessels and causing that heart to actually pump even harder against vasoconstriction would be really helpful. So I don't really know the answer, Kurt. Have you read something that would suggest that would be helpful?
Yeah, and I'm reaching out to the audience here as well, who's ever used these medication for this particular sort of group of patients. I'm only aware of vasopressin in hypertrophy during diabetes, where it seems to be on a low dose quite effective in that particular group and with improved hemodynamics. ACE inhibitors, from my memory, is only being discussed by people in the discussion section, but I'm also not aware of anybody using this. But I guess we as neonatologists don't use it, well, I would say at all almost. Well, the pediatric intensivist, particularly when there's abnormalities in the RAS system and overactivation, would actually prescribe it much easier. And I always have wondered why we're not doing that. But there's a question here. Oh, that's a very long question. Ikwan, you want to unmute yourself and start the discussion?
Yeah, thanks. Thanks, Cheryl. That was excellent. Yeah, something we don't see much of, and when we do see it, we're not very familiar how to look after them. I just had a question about the use of postnatal steroids and its contribution to ventricular hypertrophy. So in the recipient, I guess it would be nice to avoid using it to not worsen hypertrophy, but sometimes the lung condition makes it unavoidable. So the question is, do you typically expect to occur even with a standard 10-day course of steroids, or do you tend to see this more in babies who have more prolonged higher courses of higher doses of steroids?
That's a great question. So I think that generally in DART, the general feeling is that you don't get such significant cardiac hypertrophy as you would if you used a Cummings course. But as with everything, we all have that anecdotal patient that had their first course of DART, and then for some reason you were asked to do an echo, and then you see this patient has had absolutely explosive hypertrophic cardiomyopathy, which we just had very recently. So I think that's one of the reasons why I put that in there. I mean, I don't think people know if these infants who have already had hypertrophy in utero, whether they would be much more likely to then reactivate all of those cardiomyocytes and get more hypertrophy more quickly. So I put that in there because I don't know, but I think that if you were to use steroids in these infants, you would have to consider them to be at higher risk of developing hypertrophic cardiomyopathy in relation to their steroids. And so I think maybe the main thing to come out of thinking about the steroids is you should rescan a couple of days, 3 days after they've started. But you would expect that with the lower dose DART, it would be highly unlikely. But it depends what their baseline hypertrophy is before you start their steroids and how well they've adapted. But I don't know whether they'd be more likely once they've had once their cardiomyopathy is resolved, more likely then to reactivate. But certainly, you know, you see hypertrophy with steroids, even with low dose. So I think each patient's a bit individual.
Thank you.
Cheryl, I have another question. It's about, you know, we get these patients and they generally, I don't know, I would guess they're mostly like 26 to 28 weeks. 28, I think, is probably the bang on the average if you get them premature. And then we do the scan early to select, you know, can we select? So the first scan, I think, is very helpful in selecting which patient is more likely to deteriorate versus which one is not. Other scans they can do antenatally, so we are better prepared of which cases are more likely to do bad.
So when I was reading up on this, it seemed as though assessing their function antenatally was not as reliable as assessing their BNP to assess which ones are going to do worse. So I don't really know that there are any indicators antenatally from the ductus venosus or the ductus arteriosus values that the obstetricians do, that would then indicate when those patients deliver, they're going to do worse. Like, they certainly know when to try and get their fetal laser done to try and reverse all of the cardiac effects before the babies are born. So I don't think there is anything that I read about. Yeah.
Gillian, you want to ask the question?
Hi, Cheryl. Thanks for the talk.
Hi.
How are you?
Good,
Quick
good.
question. There's some data coming out from Europe with regards to management of hypertension in the recipient twin and the use of calcium channel blockers. So just harnessing some thoughts, I guess, from yourself and the wider group.
Yeah, I think that comes back to what Kurt was saying. They've got this altered renin-angiotensin system. They've got an altered response to it because they've been inundated so much from the donor. And if there's quite a bit of look at sort of treatment of persistent hypertension, in fact, in all neonates, but this would be a high risk population and I think ACE inhibitors would be quite good for their hypertension if it was persistent and prolonged. But generally it only lasts a couple of weeks and it does resolve. So yeah, I think it's a really good idea.
Cheryl, do you ask the renal physician to come have a think with you with every complex twin-to-twin transfusion case?
No, I've never done that, but I might need to start thinking about it. I think it's a really good thought. And I think that, in preparing this talk, I think that was one of the things that I learned most was about how all the hormonal changes are also shared, but they're shared from the donor to the recipient, and they're completely inappropriate for the recipient. And I don't think it's something that I'd appreciated has as much effect on the hadn't appreciated how much was actually transferred to the recipient, and therefore how inappropriate that would be if they were born when they were born. So I think it's a really good thought.
Yeah, and changing that regulatory mechanism to reset takes days, if not longer. So it's not a problem which will go away straight away, like will take away an obstruction for a coarctation with surgery. Problem solved, isn't it? Open the PDA, but this is, I also think, is different. Martin, you have some experiences you want to share.
I wouldn't say it's a lot of experience, but it is a single case experience. We recently had a set of babies with twin transfusion syndrome, and the cardiology review, one of the recommendations was to start a beta blocker and target a lower heart rate and measure left ventricular output as the outcome of getting the right level, if you like, titrating it to heart rate. And that seemed to work quite well for us. I mean, the LVA was decreased at the beginning, and then as we started esmolol, we were able to titrate it up and see the slowing of the heart rate and the improvement in LVO as measured by normal functional echo parameters. So we kept the baby on that dose of esmolol while we had to give intravenous, and then we transitioned to an oral or propranolol, I think it was, afterwards. So that was only part of the management, but I was just wondering, I mean, there's not a lot of evidence in the literature. I mean, the ANMF actually has the Australian Neonatal Medicines Formulary has a guideline for esmolol, and within that guideline, it does mention use in the twin transfusion syndrome with the hypertrophic twin. But it does stress that it should really only be started with the discussions with the cardiologist, and that there is very little evidence that we're talking 3 or 4 case series. So, yeah, so that's our experience. It seemed to improve the cardiac output and stabilize the baby. It's a very short acting, so if you overdo it, you can very quickly fix that. It was suitable for a couple of weeks of treatment until the myocardium gradually started to normalize. So. And
how much did the heart rate drop on average?
From memory, it was around about between 20 and 30 hearts beats per minute. That sort of order.
Yeah, that's a significant drop indeed in
I mean, you can titrate it, Kurt, against the against the heart rate, and we actually worked out which heart rate seemed to be the most efficacious, and then the instructions to the medical staff were to titrate the esmolol to keep the heart rate in that range. Has anybody else used esmolol or a beta blocker in this setting?
Not in this setting.
We discussed it a lot for this particular infant, but we seem to be able to manage with fluid loading. But that was going to be our first approach before ACE inhibitors. We were going to think about a beta blocker.
All right. Any other questions from the audience? Complex topic. Sheryle, again, thank you so much for presenting for us and for this group today. A good discussion, and sometimes case reports are still important, isn't it? Where we just report our experiences, whether right or wrong, with enough detail into it, so we can use that to generate sort of considerations at our next cases. And we always want, the biggest randomized trial, but it's just, of course, never going to happen. And we're not even going to get a large cohort series if we talk about these kind of complex cases. So keep writing case reports. You don't hear me say that much, but I think it's still important for these little aspects. Well, thank you all for attending. There's another session next week. I hope to see you then. Thank you so much.
Thanks, Sheryle. That's a great talk.
Thanks.
Thank you, Kurt.
Okay, thanks everyone. Bye.
Recording stopped.